What's going on, everybody? Welcome back to another episode of the Core Consult RX podcast. Cole, AJ, what is going on, gentlemen?
Nothing much. We got the whole crew.
Got the whole crew. We even got Zoe.
Yes.
You can't see Zoe. But we're watching my wife's new French Bulldog, and AJ's holding her, and she weighs like 3 pounds, so
Mike,
she's in the jacket.
Mike has a lot of animals in his house. He always has, but I think this is the first guest appearance we've had of any of the animals on the podcast.
She's quite small still. But it's either this or she's going to be crying downstairs because my wife's still at work.
So, this is so y'all don't have to hear at least this dog bark. There could be other dogs barking.
Yeah, the other two downstairs will probably bark, but that's all right.
You know, we've never had a comment about that. Though the dogs have barked on so many episodes.
So many episodes. I would say 100 out of 176.
Easily. Now people are going to listen for it.
Yeah, and it's going to be
It happens more often than our phones going off, which also happens a lot.
It's true.
Yeah.
Not a lot of professionalism that happens around here. Really, as much effort as we put into this.
I silence it at least half the time.
And then what ends up happening is I keep it on vibrate, so it still makes noise.
You still hear the buzz.
Yeah. So, it is what it is.
Yeah.
We tried. But, so we are going to do a topic that we're like 95% sure we have not covered since 2018.
Yeah, it's been a long time.
Not a whole lot of changes, but we're going to cover dry eye disease because there is a new drug that came out in October 2021 that, it's new formulation, new indication, not a new drug.
That's a good point. Yeah, not a novel drug, but a new drug for this class.
In a weird indication that we were all just kind of talking beforehand, not quite sure how they came up with this, but seems to be effective. So
good cliffhanger.
Yeah, we're not even going to tell you what it is because we're going to let you listen to the end of the episode.
You have to listen to the whole thing.
The whole episode. Don't you even fast forward. So what are we talking about, Cole?
Yeah, so dry eye disease. There is medical terminology to describe it, which would be keratoconjunctivitis, sicca, right? Before we get into some of the signs and symptoms and whatnot, we'll just give you some risk factors and a little bit of a pathophysiology overview. There are some risk factors for having dry eye disease: advanced age, female gender, hormonal changes, primarily due to decreased androgens. Systemic diseases like diabetes and Parkinson's, wearing contact lenses puts you at increased risk for dry eye, and a few other things. Depending on what the weather's like where you live, a low humidity environment would put you at higher risk. Surgeries and procedures, especially a corneal refractive surgery, decreased corneal sensation, ocular medications is very common. So especially ocular medications that contain preservatives, and then also systemic medications like antihistamines, anticholinergics, certain estrogens, and SSRIs can all cause dry eye as well.
So when we're thinking about from a pathophysiology standpoint, it usually is kind of revolving around two different sort of pathways. It's either just an overall decrease in the actual tear production, or it's kind of centered around increased in evaporation loss. So you basically have an excessive water loss from the ocular surface. So when we're thinking about decreased tear production, a healthy tear film is really kind of relying on this sort of lacrimal functional unit that makes up of the lacrimal gland, the eyelids, and the ocular surface. And so together they have to function as this unit. And if any of them kind of have any sort of dysfunction, the actual lacrimal functional unit starts to kind of implode, if you will. That's probably an excessive term for that, but and it starts to form this just excessive chronic dry eye situation. And it can be from a few different things that kind of leads to this. One kind of major thing to consider is Sjogren's syndrome, which is an autoimmune disorder in which there is this inflammatory infiltration of the lacrimal gland itself, and that's going to basically lead to cell death of that the cells that make up that gland, and then basically leading to tear hyposecretion. Now, with Sjogren's syndrome, you're typically going to see other kind of systemic effects of this as well. So a lot of times you'll have dry mouth as well, and there's other signs of inflammation and more almost like a rheumatoid type situation in some cases. So we'll get to that when we talk about some of the treatments, but from a non-Sjogren's syndrome aspect, it can also just be kind of a deficit of aqueous tear production. So dry eye is involving lacrimal dysfunction itself, and that can be just kind of localized without having any sort of systemic findings or anything like that. When it comes to increased evaporation loss, we have this excessive water loss from the ocular surface, and then we don't really necessarily have any lacrimal dysfunction, but it still can lead to this tear film instability because you're having this excessive water loss without kind of like bringing in replenishing the tears on the ocular surface, and so it ends up causing this cycle of tear hyperosmolarity and lacrimal function unit inflammation. It's basically leads to eventually this vicious cycle that ends up with, again, decreased tear production. And that can also stem from like structural abnormalities of the eyelid position or, actually centered around like the blink function of the eye itself. And all these things can kind of increase evaporation of the tear film and lead to, that, again, chronic dry eye situation.
Yeah, and there are actually a couple different terms for it as well. Dry eye syndrome would be the same, and also keratitis sicca would be another shorter, easier way to say the medical term. All those you may see, and that all just means dry eye disease.
Yeah.
So there's some common complaints. This is how you're going to identify it. Of course, there's going to be dryness in the eyes, but also red eyes, general irritation, a gritty sensation, which I hate it when I have a gritty sensation in my eye, burning sensation, a feeling of a foreign body, excessive tearing, light sensitivity, and blurred vision as well. All of these would be complaints that the patient has. It's very uncomfortable, so we're going to look for ways that we can mitigate those.
And I think kind of a big takeaway too is making sure that you've sort of established, a patient history, finding out how long, because all of us have had, dry eyes or red eyes from, staying up too late or working on a computer too long, studying, pharmacotherapy for too long.
Or staring at a box fan for 10 minutes without blinking. Or
right.
Or blinking contests when you're at a restaurant with your brother.
Mm-hmm. Yeah. All good examples, Cole.
Mm-hmm. And sticking your head out the window, going over 60 miles an hour.
Yeah.
Not blinking.
If you're going 57, you're fine, but 60,
yeah,
done.
Mm-hmm.
So getting a history of, and kind of like a progression of the patient's symptoms, then and kind of their sort of historical recap of what led to them actually seeking treatment. And then we also want to establish sort of like a baseline of the, and come up with a way of quantifying the symptom severity, if you will. So just like we have with a lot of our behavioral health disease states, we have questionnaires that we can utilize in this setting too. So we have like the Ocular Surface Disease Index, the OSDI, which is basically just a 12-item questionnaire that's going to help evaluate someone with dry eye disease. And it can be really useful when it comes to monitoring the response to therapy after it's been started for patients that have more severe symptoms at baseline and seeing how they improve over time and how well the therapy is using. And it gives, other than just saying, yeah, I feel better, man, it's not that much better. At least this gives you a way of kind of at least sort of quantifying it with a numerical value. And we also have things like the dry eye questionnaire or the DEQ-5, which is a abbreviated like 5-item questionnaire to determine the dry eye disease symptom severity. There's the Salisbury Eye Evaluation Questionnaire. There's several others, and so just, depending on what clinic you're working for, they may use different tools. You may use multiple tools. It kind of just depends. But it's, again, a way of sort of establishing a baseline and then having some way of tracking the improvement or lack thereof over time.
Yeah, I like these questionnaires. You don't want to ever get too attached to a questionnaire, but it can definitely help guide you. What do you think when you hear the word Salisbury?
Steak.
Always the steak, right? Mm-hmm. I specifically think of those banquet frozen meals that you can get for like $1.25 from Walmart.
Yeah, they're disgusting.
Lived on, I don't know. They have a special place in my heart from college, along with ramen, which I still eat on a regular basis.
I eat ramen noodles like a cracker. Like I eat them like a.
I've seen people do that.
That's what I do. I've never in my entire life. I've eaten ramen noodles a million times. I've never once put them in water and heated them up like a normal person. I really haven't.
Do you put
psychopathic?
That is actually
AJ, how dare
very
you.
much so. Do you put the seasoning on it?
No.
Do you eat your cereal dry too?
I don't really eat cereal.
Well, that's a problem.
No, dude, cereal's terrible for you.
Okay, yeah, and ramen's great.
I don't eat ramen that often. I'm just saying. If I have ramen,
was the quote a million times, AJ? Can you play that back?
Okay,
I think
a
you said he
million
ate it a
times.
I
million
thought
times.
we were recapping to back in the day when we didn't have any money and we were in school, so that was a lot more frequent then. Now I eat normal people food.
I have one of the I don't know where it's from, but it's just this little plastic thing that you drop the block into. And it's
That's
made,
fancy.
it's like a ramen cooker type of thing. My brother makes fun of me because I told him that I brought this ramen home that advertised that it was like 50% less sodium, right? Because that's the big issue
It's only 2,000
is the sodium, right?
now.
And I was like, and my brother always talked to me about how unhealthy it was. And I said, well, look, this is 50% less sodium. So I start to make it and I open up the package and it says, ramen, 50% less sodium, just add half of the seassoning packet. Like,
that's
great.
genius.
Fantastic. But it advertised right there, boom, blue, 50%.
It's not wrong.
No, that's not wrong.
Ramen's doing big things. They're on another level.
They are. You ever doctor it up with some cheese?
No.
I never
told
did
you
that
I never even cook it.
Okay. Well, some people, they'll put a little slice of American cheese underneath
Sort of
and heat it up.
nacho. I'm going to take the cracker version of it and just put cheese on that. Have a nacho form of ramen.
It's a thin line between psychopathic and culinary arts.
And that's the line.
And
a little H2O with your ramen. Right?
And I'm the line.
That is the line.
I'm basically a chef. Anyways,
you want to talk about some treatments?
Off topic. Yes.
Okay. Well, you have a little too much salt. You probably could add to some. Never mind. I was going to try to transition, but
and there's the dog.
If you salt your eye, it's going to be dry. How about that? Okay. So we have a couple of options, and for the most part, our options are going to be topical things that you either instill in the eye or apply to the eye. So we have artificial tears. You've probably generally heard that term. It refers to a few different branded names that you'll get over the counter or prescription. Usually these are given up to 4 times a day. And we're going to throw a lot of brand names out, and we're going to try to associate them with the generic name. But generally, you can look at these things and think, oh, yeah, that's artificial tears. So Refresh Optive, or Optive, is carboxymethylcellulose. That seems to be the one that I'm the most familiar with. Genteel, moderate to severe, is hydroxypropyl methylcellulose. Blink Tears is hyaluronic acid formulations. And then there's also Next Step artificial tears. So that would be like Sustain Ultra, polyethylene glycol 400, and Soothe, which is a combination of glycerin and what else?
Propylene glycol.
Propylene glycol.
So the reason we kind of have them separated out like this, if you look at the ophthalmic drops section of any like or community pharmacy, CVS, Walgreens, whatever, there's a gazillion eye drops in that section. So, when it comes to sort of, even if you look at like the UpToDate article or Medscape, when they mention, sort of artificial tears, they just kind of throw that out there. They just say artificial tears as if like they're all sort of equal. So there's actually this meta-analysis that basically took as many different trials as they could find that were comparative studies, and they took all the different sort of active ingredients of all these different brand names and then did their best to compare and contrast and look at actual efficacy. And so the few that Cole just mentioned, when it comes to the original like artificial tears, the carboxymethylcellulose and those, they were basically saying, okay, if you have to pick a starting place, especially if it's more mild, symptoms, and you don't want to kind of escalate, therapy right away, then these are like true like artificial tears. Usually you can start treating 3 to 4 times a day with any of those, like what he was saying, Refresh Optive, Blink Tears. And it's a true like artificial tear. It's the same consistency as a tear. It's very very low viscosity, and from there, if you need something further, if it's not enough to kind of get control of the symptoms, then you can kind of escalate. A lot of times, I think of the polyethylene glycol and the glycerin and propylene glycol combo is sort of like gel tears, where it's still a liquid form. If you were to see it, it's still has liquid consistency, but it's a little bit more viscous. It's got a little bit more stick to it, if you will. And so the issue is, one, it can cause more like issues with blurred vision and stuff, and especially as we go further into like the gels and ointments we're about to talk about. But the reason they kind of came up with this, it's not like it's imperative. Like if you started the Sustain Ultra, the polyethylene glycol 400, you did it wrong. It just gives you an idea so that you're not just jumping around all over the place.
Yeah.
And it's, it kind of gives you a stepwise approach of like, okay, if you've tried this and that's not working, you can escalate by doing this because it's more effective.
Yeah.
You can also start, further up the algorithm as well. But if you check it, and I can post a link to the article itself, but there's this really nice kind of algorithm that they show. It's a picture of an eye, and it's got to start at the top, and it kind of moves around the eye in a circular form, and it starts to escalate. If refractory symptoms, then move here. If symptoms still persist, then move here. And it kind of just gives you some sort of method to follow, so that you're not just picking random agents over the counter and just trying that, because it's hard to keep track of like what's working, what's not working, if you're doing it that way. So it also keeps the patient from wasting money on things. If you've started with propylene glycol glycerin, and then that's not enough to get control of the symptoms, going back to like the carboxymethylcellulose is probably not worth your time, because it's probably not going to be effective. So
right.
If you're sitting here going like, why are they being so specific about this? That's what it's there for, just to kind of give you some kind of guidance, because it hadn't really ever been established before.
No, it's good, because I think if you just say artificial tears, then the poor community pharmacists out there feel like they still don't get any additional guidance. I know for me, and probably for a lot of people, they just end up with whatever their go-to is, and they say it confidently to the patient, and the patient's like, oh yeah, then that must be, pharmacist told me that's the best thing. But really, it's because maybe we've heard people say it works, or we know that it doesn't have extra stuff in there that we don't want it to have, like it's plain carboxymethylcellulose without an antihistamine or something. So we're like, yeah, go for that one. That's probably the best thing to start with. But I like a stepwise approach with some guidance.
Yeah, and like I said, it also gives actual brand names in the article, which I think is, you don't see that too often, but because there's so many different formulations, I think that's really cool that they kind of put them together like that. So it's way more about eye drops than you probably ever want to read, but
it's a super common question, though.
Yeah, it is, for sure. Question. So I'll put the link to that article just so you can check it out, because I think you can download it for free. So if you really want to dive into it, you can, at least if nothing else, have that algorithm. Okay, so we talked about artificial tears, and then move up to like what we call kind of like those gel tears, and then from there, if that's still not enough to kind of get control of the symptoms, then we can actually move up to a true like gel formulation, or what they call a lipid formulation. So about the same consistency of a gel. It's still obviously not quite as occlusive as an ointment, but definitely a lot more viscous and thick than any of the artificial tears that we've already dealt with. So some brand names would be like a Gentile gel, and then for a lipid formulation, we have like the Liposic. And again, it can be more effective as far as like, sort of like soothing the eye, causing, that lubrication in the eye. But it's going to be a lot more irritating to actually apply, potentially blur the vision a little bit. And so I know I personally would want to try an artificial tear, because it's a lot easier to put a drop in than it is gel in your eye.
Yeah.
But if it's not enough with the artificial tear, you can definitely escalate to that. And then the next step from there would be going to the ointment. So as an example, like the Refresh makes one called Lacrolube, and it's a very thick actual ointment vehicle. It's the artificial tear is placed in, basically, and it can definitely blur your vision for quite a while. I mean, up to 20 minutes in some cases, if and it'd be a little bit irritating. So maybe better for someone before they go to bed or something like that. Plus, you have to make sure that you spend time kind of explaining that they need to pull the eyelid down and sort of put the ribbon, if this is the way they always explain it in the the standard directions that get sent over, but the ribbon along the bottom eyelid, and then make sure the patient rolls their eye around on that ointment to kind of spread it out. But definitely not the most comfortable thing, but as far as efficacy, probably the most efficacious when it comes to those over-the-counter artificial tears. There's also a liposomal spray, which is like tears again is the brand name for that. I don't know that I'd be putting the spray in my eye. I've never tried it, but I guess we could try it and put it on YouTube. But
yeah, I don't want to bash it till I try it. But if I'm in the development room for a dry eye vehicle, I don't think I'm going to go for spraying something directly in your eye. Yeah, it's bad enough to have to roll your eye against an ointment, right?
Yeah. Definitely not a big fan of that. But again, I'll post the article if you guys want to check it out. And they do talk about, in the article as well, considering sort of the potential for preservatives versus a preservative-free. And the problem with the preservatives, obviously, we want to keep the eye from getting, or the eye drop from being contaminated, because then we don't want to give conjunctivitis and bacterial or viral conjunctivitis on top of all this. But the most common preservative that you'll see, especially in the over-the-counter multi-dose vials, is the benzalkonium chloride, or BAK, B-A-K. And then if you use this for long periods of time, because they recommend using these for about 60 days to really kind of, in multiple times per day, to kind of see if it's going to take effect. It takes a while to kind of clear up this condition. And that time, it can actually cause damage. That preservative can cause damage to the corneal epithelium and actually disrupt the tear film further. So it's kind of like counterintuitive to, if you do have someone who has true dry eye disease and not just their eyes are sore from staring at a computer screen, and they're going to have to use this long term, it may be something that is worth spending a little bit extra money and getting the single dose vials, because then you don't have to worry about the preservative. You don't have to worry about that kind of rebound irritation and dryness or disruption of the tear film. Some of the newer agents do have some different preservatives in them. However, it's still basically the same concept. Over time, it can cause damage and lead to worsening outcomes overall. And so, again, if you have a patient who's got true dry eye disease, it may be a good idea to recommend the single dose vials that they can use and throw away, and that way they get a fresh one each time. And don't have to worry about the preservative.
Yeah.
It's one of the rare times I'll say use the more expensive one. It's probably worth it.
And even generally, we're not, super concerned with preservatives and other things with medicine, but with this, it turns out it matters. And if you're ever wondering, does this have a preservative? Does it not? Like if a patient's asking, single dose vials, no preservative because they're single dose and they're intended to just be used once, thrown away. Multi-dose vial is going to have a preservative because it can be opened and be good for a long period of time. Which kind of brings us to some other options as well that are prescription. So one is Restasis, which we've all heard of and is used for a number of eye situations, but it's a cyclosporine eye drop. Studies have shown benefit in patients who suffer from different degrees of dry eye. Not all patients will see benefit from it. It can take up to 6 weeks or longer to be effective, so it takes a little while. Side effect wise, a burning sensation of the eye, but for the most part, it's pretty well tolerated. There's not really a concern for systemic toxicity. Serum concentrations of cyclosporine have been undetectable or negligible with topical use. So there's not really a concern for systemic toxicity. But I guess a couple years ago, they came out with the multi-dose vial. So in general, or before that, it was just the single dose, I don't even know what you call those little things. Just like a plastic ampule almost, right?
They call them vials, but
vials.
Yeah, they look more like a plastic.
Yeah, they're not quite a vial, but like a plastic little ampule that you twist off, and you'd get them in the big boxes of however many of them, 60 or something like that. Yep. But now they have the smaller multi-dose vial, which is a little more expensive, but and of course, would have a preservative in it, but it's available too.
And if you look so the way I think about this is, if I have a patient with chronic dry eyes, they haven't tried anything yet. Okay, let's try the topical ophthalmic drops, the artificial tears, and then kind of escalate through that algorithm that we have. If that's not enough and we have to go systemic, the Restasis, like Cole just mentioned, and the next two drugs we're going to mention, I kind of think of those as being like, okay, let's kind of pick based on patient-specific parameters of how, between those three, because it's hard to tell which one of those is truly more effective because there's no head-to-head studies. And if you look at the, placebo or comparative studies, it's kind of hit or miss as far as the efficacy. So I will say, because cyclosporine obviously is helping with the inflammatory concept of the potential patho going on. If a patient does have like Sjogren's syndrome or something like that, where there is this inflammatory component to it that is an autoimmune, you may get a little bit more of a benefit out of those patients with Restasis versus someone who doesn't have any sort of like inflammation going on. It may just be that excessive evaporation of the ocular surface tension. So just food for thought on that. Keep that in mind. If you're looking for some of those rheumatoid labs start showing up and there is some signs of inflammation, that may be, you're definitely worth the trial of Restasis.
Right.
We also have Xiidra, which again is a separate class of medication, but when you look at the studies, it's versus placebo. They don't have head-to-head studies like with Restasis. The improvement was seen compared to placebo when it comes to the signs and symptoms of dry eyes, when it comes to mild to moderate, as well as moderate to severe. They've both kind of symptoms have been, severities have been studied against placebo, and you do see improvement. That being said, again, it's not like every single person who starts it is going to see that improvement. So it is potentially hit or miss, and it can still cause some eye irritation with the topical use of it. The one thing to keep in mind with this in particular is about 25% or more of patients complain about tasting a very metallic bad taste in their mouth after application. So you will actually get some of it that drains into your your sinuses and down in your throat, and you can actually taste it. I haven't personally tasted it, but I've heard it's pretty disgusting. So that is one of those things. It sounds stupid, but I can say from someone who only had to take Plexovid for a few days, that taste, that metallic taste that lasts all day, is definitely disgusting.
Yeah.
So
like sucking on a penny.
Ugh, it's gross. And so this having to do that for a long period of time. I mean, you're thinking 4 to 6 weeks before you're going to see improvement. That's a long time to be tasting nasty metal in your mouth.
Yeah.
Just keep that in mind. The cost is also an issue. Thinking somewhere in the ballpark of around $10 per dose, potentially, maybe a little bit less now, but that's still pretty pricey. So one, the patient's going to have insurance, and also making sure that this is covered. The prior authorization is probably going to recommend or probably require that they've tried all these different artificial tears first.
Restasis, probably.
Yeah, and so it's something that you have to keep that in mind. And again, be realistic with the patient's kind of expectations when it comes to how quickly their symptoms should resolve, and if it's even going to resolve.
Right. Yeah, you'll see a lot of commercials for that one.
Yeah.
At least I do. Okay, so that brings us to the new kid on the block. You waited all this time, and now we're going to give it to you.
All this time.
So the brand name of it is Tyrvaya, which I can only imagine is a look-alike, sound-alike with Tremfya. I mean, my goodness, right?
Yeah.
So it's varenicline, which we're all familiar with that. If it's ringing a bell, it's Chantix. This is a nasal spray. It was
nasal spray for your eyes.
So not only is it Chantix, not only is it varenicline, but it's a nasal spray that's going to help your eyes, which obviously is possible because we kind of do the opposite with our glucocorticoid nasal sprays to kind of dry the eyes up a little bit in a different situation. Relatively new, approved in October 2021. How it works, so it's a partial agonist to several subtypes of alpha and beta receptors. It's also a full nicotinic acetylcholine receptor agonist, right? So that's how it has some of its effect with helping people stop smoking cigarettes. It's a cholinergic agonist. So it activates the trigeminal parasympathetic pathway, resulting in increased production of basal tear film, which is how it's going to help with this. As far as its studies, there was a significant increase in tear production after 4 weeks of twice daily dosing, and it's relatively well tolerated. Cough, sneezing, throat irritation. So I can only imagine that it just doesn't have the same systemic, maybe, side effects, concerns that Chantix does with the dreams and whatnot, that sort of thing.
Yeah, I mean, I have to look and see how much. I don't think there'd be much systemic. I will say too, it's weird because we always think of anticholinergic. That's the term we always throw around. But in this case, you're actually trying to do the opposite, which is something we don't really talk about all that often, I feel like.
Yep.
And so when you think about the adverse effects, it completely makes sense, right? Because anytime we think of anticholinergic, we're thinking of all the secretions drying up and sort of the blurred vision comes from the dry mouth and all that. But in this case, you want to have that tear production. And so you actually want to have cholinergic activity, which is then going to cause those secretions to be released. So the cough, the sneezing, throat irritation, a lot of that's going to just be because the sinuses are draining and you're getting post-nasal drip and some irritation, and just like you would if you had just random allergic rhinitis causing post-nasal drip or something like that. So side effect wise, not anything too crazy. And like I said, or Cole said, it's fairly new. So as far as its place in therapy, even the up-to-date article is very limited as far as what it actually explains about this. So it's going to be interesting to see as time goes on how this is kind of recommended as far as its place in therapy. I think it's just a matter of more time and seeing how people respond to it. I did look up the price last night, and it was around $700-800 AWP. So it's definitely not cheap, and something that I'm curious myself to see how people respond to it. I haven't seen anybody on this yet, but
You know what I'm curious about?
what are you curious about?
Is there a way to make it work for smoking? I imagine not, right?
You have to drink the nasal spray.
Have to drink it, though.
Don't do that.
But
I'm
what if
just
they, obviously they're not going to get it to the brain through the nose. But what if they just sprayed it really hard?
Maybe
Really,
you're onto something.
Really, just shot it up there, straight up there, really hard.
Yeah.
We might could get some benefit with some smoking.
If any of you guys are on this drug and you're a big smoker, let us know. If you decide to spray
if this fixed your smoking habit, I'd like to know.
Yeah, I'm definitely curious to see if there's going to be any kind of systemic absorption that's reported. The other thing is too making sure that when it comes to the actual administration, just like any other intranasal spray, it is important to kind of take a look at the administration directions, because it's not always as straightforward as you think. So, for example, in this one, it does actually say, so just in case you guys didn't realize that was me joking when I said spray it in your mouth, it actually says in here, do not spray in your mouth. So apparently it's not good for you. But nostrils only, people. And it says do not shake the bottle, so it's not a suspension or something like that. And you actually have to prime it. So you have to press 7 times into the air, away from the face prior to the first use. And if it's sprayed, if the spray is left unused for more than 5 days, reprime with 1 spray into the air. You want to tell the patient to blow the nose if needed to kind of clear the nostrils. Tilt the head back slightly without laying down. You don't want to be over dramatic about it. And then tilt the head back slightly, like I said, and then insert the applicator into the nostril, pointing the tip towards the top of the ear, leaving space between the tip of the applicator and the wall of the nose. And then listen how specific this is, place the tongue on the roof of the mouth and breathe gently while pressing the pump to release the spray. This is already way too complicated. I would mess this up immediately. And then it says do not spray directly at the septum, and wipe applicator with clean tissue. A clean tissue. Do not reuse your nasty tissues. After each use, a 1 month supply consists of 2 bottles. Finish the first bottle before opening the second. Don't get overzealous and open the second bottle. You got time.
Just really excited about it.
Yeah.
I want to know how many people just stuck their tongue on the roof of their mouth and then inhaled through their nose a little bit. I will say that it makes it a lot easier to only inhale through your nose and not your mouth. That's a great idea.
Yeah.
Like next time I'm doing Flonase, tongue on the roof of the mouth.
So get this, varenicline is absorbed somewhat systemically because during the pregnancy considerations.
Right.
It is absorbed systemically following nasal administration. So concentrations are approximately 7.5% of an oral 1 milligram dose. So very small amounts.
Very small.
I doubt that you're going to see much smoking cessation effects with that low of a dose, but you never know. Maybe if you're on like a 1 or 2 cigarette kind of guy. Then maybe you might not need enough.
I think to that point, if you use it kind of like I use an albuterol inhaler, and just how many ever pumps you need to get the effect, I use about maybe 7 or 8 pumps. Four to 6 times a day. You'll get there.
Great recommendations to give everybody.
Thank you from the executive producer. Nobody will take that advice. That is complete nonsense. And stop using albuterol anyway. That's preposterous. Use Symbicort if you have asthma.
For y'all in the South who get a
y'all.
Oh, wow. For you all in the South, you guys in the South who get a Pro Air inhaler brought to you and saying that it's not working anymore, take it out, take the cartridge out, rinse it through some warm water, squeeze it, it'll work, hand it back to the patient.
Yep.
Prevent you from having to do it. Also, if you're interested in looking, if this really piqued your interest, this varenicline nasal spray, it was investigated and approved through the Onset 1, Onset 2, and Mystic trials. So feel free to read more about it. The Mystic. They made it sound pretty cool.
That does sound cool. And then you're like, wah wah, just varenicline nasal spray. So there you go. That's the new kid on the block, and we'll see how it plays out. See if it gives Restasis and all that a run for its money.
Be surprised, but
my guess is no.
Maybe. I mean, people who are refractory and have tried the others, then sure, they got another option now.
Yeah, absolutely. That's the good thing, is at least we have another option we can try if it's not working. And, you can always still combo up with some of the artificial tears on top of these more. This is not using the same route of administration. Now you got nasal and eye. You can come at it from 2 different angles to get to the same result.
Yeah.
Maybe.
Hopefully.
AJ, anything else we miss? It's a short and sweet episode today.
For a refresh optive, the sponsorship can email mcorvino@outlook.com.
Yep. Yeah, if any of you eye drops that want us to push your product, as long as you're on this list that we have on this algorithm, otherwise we're not taking your money. But yeah, speaking of sponsors, big thanks to Pearls. If you haven't checked out the app yet, they were our first and major sponsor, and they've continued to support us. So check out www.pearls.com/coreconsultrx. It's free to sign up for the initial kind of the enough of the application to get some solid use out of it, and then from there you can decide if you want the pro edition, if you will. But you'll get some cool charts and some really good pharmacotherapy algorithms and whatnot that you can utilize, even with the free version. If you go through our link, I'll put that in the show notes too. So big thanks to them. And if you want more like lecture style content, definitely check out Patreon. So patreon.com/coreconsultrx, and we have PowerPoint slides and actual like lectures on there instead of us getting sidetracked every 5 seconds. If you have any questions for Cole, myself, or AJ, emails will be in the show notes. AJ, I'm starting to get emails with your name in it now, like addressing all three of us.
Good.
I love it.
Good.
Yeah, that's appropriate. So I'm happy for that. So thanks, guys, for including AJ. I'm glad he's our executive producer. Don't forget it. And if you want to send us a text directly, 415-943-6116. And, we're always open to suggestions or things we can do to make the show better. Or if you want to be a guest or you have some cool ideas for content, definitely let us know. We'll do our best to make it happen. Thanks for the support. As always, we'll see you guys in the next one. Have a good night.